Welcome to our presentation about BAS models for EHR, RIS and PACS diffusion in Finland and in Germany. My name is Jens Hüsers. I'm a research associate at the University of Applied Sciences in Osnabru, and together with my German and Finnish co-authors, we constructed and created BAS diffusion models to explain and compare the different characteristics of the diffusion process. So let's start to see what it's about. Okay, in this intro I want to speak about the national e-health strategies that promote healthcare digitalization. In the past 20 years, we saw a growing attention of national health policymakers around the globe in this topic. Many countries spawned various e-health strategies to promote digitalization. And today, years after the initial political campaigns came or should have come to fruition, different outcomes of their endeavors became apparent. So that's what we want to talk about. Specifically, the Nordic countries are recognized to have championed their pursuit of adopting national e-health structures. So Finland had adopted inter-organizational EHRs in all national hospitals by 2007, as the data show. And Germany still is struggling today with intra-organizational electronic patient records. So this lends itself for an interesting use case to model the uptake of three systems: RIS, PACS, EHR systems in Germany and in Finland. So the diffusion dynamics have not been modeled statistically so far, and the models allow for an in-depth understanding by interpreting the available model parameters. And they can be reflected against the background of those national e-health strategies. Now, with longitudinal data on the adoption rates are available, it appears valuable to contrast Finland, as an example of a Nordic country, and Germany with respect to their diffusion curve of core HIT systems. As such, we investigated radiology information systems and picture archiving and communication systems because they are clearly described in their function. Furthermore, we look at EHR because they are more complex due to their larger spectrum of functions. So in this thesis, the central research purpose was to describe and model the uptake of these three key HIT systems to contrast and investigate Germany's and Finland's distinct diffusion dynamics. The data sources we used was, for the German part, the IT Report Healthcare. That's an ongoing national research initiative that regularly surveys the digitalization of healthcare delivery organizations. We do so since 2002. And for this study, we used 6 separate surveys that were conducted between 2005 and 2017. The surveys addressed hospital CIOs who reported their IT infrastructure. The Finnish data stem from national surveys of the Finnish Institute for Health and Welfare, which were commissioned by the Ministry of Social Affairs and Health. The Finnish data contained hospital adoption rates for the period between 1999 and 2017. The models we used are recognized as the BAS diffusion models, which build on Rogers' diffusion of innovation theory. The well-established BAS model mathematically describes the diffusion pattern of innovation by considering two effects. And those two effects are described by its two model coefficients: P, that's the innovation coefficient, and Q, the imitation coefficient. To remember it, I often say that P looks forward to the right and Q looks backward. So this is the innovator that looks forward, and Q looks at the innovator and imitates him or her. So P and Q are interpreted as innovation imitation. This is actually the result. In the upper row, we see the Finnish data, and in the lower row, the German data. And for each column, we have a specific system. You see that the BAS model revealed distinct patterns of diffusion in German and Finnish hospitals. So for Finland, the data showed a quick and almost similar uptake process across all three HIT systems. The model reflects this pattern through the high coefficient of imitation, which you can see in the appendix. albeit with slightly faster adoption of radiology systems, which were introduced after EHRs. So, however, Finnish hospitals had achieved full adoption of those three, of RIS, PACS, and electronic records in 2007. In contrast, the BAS models mirrored a slower uptake in Germany compared to the Finnish data. Germany had a higher P coefficient, that's the innovation coefficient, but lacking imitation effects, as it is indicated by the low coefficient Q, eventually failing to reach full adoption as of today. One common feature of diffusion patterns in both countries was the slower adoption of electronic health records compared to the radiology systems. That are the main findings we extracted from the BAS models. So when we discuss the diffusion model and its key characteristic, we see that in the diffusion process there was a higher coefficient of innovation in Germany compared to Finland. So there are existing initial innovators, but only a few peer institutions followed suit in Germany, in notably slower diffusion and failing the complete uptake of those three systems on a national level. The lack of imitation may also indicate missing network effects between hospitals or in the healthcare system in general. So in Germany, we often talk about this lack of networks as the sector boundaries in which most clinicians and administrators think. In contrast, Finland, for which the model showed high imitation effects, witnessed quick gains in digitalization hospital care. So, the size of both countries can partly explain these findings, but in addition, governance and financing structures, large-scale standardization, and nationwide coordinating functions for implementation can ease or hinder implementation efforts. However, the political environment in which decision-making and enforcement of these decisions occur could be even more important. So let's look at Finland. There, the ministry is the highest decision-making authority that oversees the municipalities responsible for providing the care and can, as such, make decisions on a high level that are then required to follow by the institutions. In Germany, the national health system is governed by the Federal Joint Committee, a committee representing different stakeholders, health insurers, hospitals, and physician associations, that decides on binding regulation putting healthcare acts into practice. And those stakeholders never agreed on how to proceed with the German healthcare digitalization. So there is maybe a point of failure. So in general, to discuss the limitation, the main limitation is related to the different findings in Finland and Germany and their comparability, because in Germany we have to consider the EHR as intra-organizational systems, which do not necessarily communicate with systems outside the hospital. However, in Finland there are intra-organizational EHR records, so the Kanta project, which exchanges health information of patients across different healthcare organizations. So we have to be very careful when we compare the German EPR, which is a patient record in the hospital, and the Finnish EHR. So in conclusion, the BAS model revealed distinct characteristic of hit diffusion patterns in Germany and in Finland, with Finland showing a noticeably faster uptake and early nationwide diffusion. In general, I want to note that the BAS models predict that we in Germany fail to reach full adoption of EHR systems. However, recent legislation suggests otherwise, because now there is much funding in the hospital sector by the federal government to support the digitalization of e-health. So there is the Hospital Future Initiative, and we expect that this law will facilitate the uptake and that we will close the gap to other nations. Thank you very much, and if you have any comments on this, I'm glad to hear. Thank you.